All right, today I'm going to talk about a very common issue that you're going to be presented with, obstructive sleep apnea. But I also really want to spend a lot of time focusing on obesity hypoventilation syndrome. This is something that's not intuitive, that you really need to be taught. Um, my first experience with it, I did not recognize it, and it led to a very challenging situation. So I want to spend some time really diving deep into OHS. So we're going to talk about how to, when a patient's in front of you, how do you know if they have obesity hypoventilation syndrome or potentially have OSA or at risk for OSA? Want to look at the difference between these two conditions. And we want to say, how does this affect us as anesthesiologists? And then how do we manage the patients? So obstructive sleep apnea, repetitive episodes of apnea or reduced inspiratory airflow due to upper airway obstruction during sleep. So if you're watching someone sleep and they're snoring, probably a reduced flow during that snore, real loud snore. That's a hypopnea. So reduced airflow, hypopnea. And apnea is when you're watching in person and there is a lack of sound, a lack of air movement. That's an apnea. So obstructive sleep apnea is defined by repetitive episodes of either apneas or hypopneas. Now, obesity hypoventilation syndrome, you have to have a few things. You have to have obesity, right? So BMI greater than 30, and you need chronic alveolar hypoventilation. So what is alveolar hypoventilation? Alveolar hypoventilation is the inadequate alveolar ventilation that leads to elevated PaCO2. But this is in the absence of comorbid lung disease. So if you have a patient in front of you with chronic obstructive pulmonary disease with an elevated PaCO2, then that wouldn't apply to this definition. So this definition is where the obesity itself, and I'm going to really dive deep into why it occurs, the body just cannot keep up to keep the CO2 normal. Now, these are comorbid conditions, and most people with obesity hypoventilation syndrome have coexisting OSA, but it's pretty infrequent to have OHS with OSA. But when you have a patient who has OHS, it has a lot of implications for your management. So I'm going to just quickly screen share this video. Give me a second. All right. So, but they're saying by 2032 that we will have a 50% incidence of obesity in the US. I think we're roughly in the third now range. But here's some data. So, never mind the white states, but the light blue is a less than 10% obesity trend, and this is as the years are going through here, and you can see that as time goes on, the obesity is trending upward, and then each year there's more and more prevalence, and then they have to make new categories because it's just so prevalent. And the point of this slide is it's going to keep going in this direction, and so we have to make adjustments and make sure that we deal with the situation in front of us. So again, this data ended 11 years ago, and you can see which way it was going. So obesity is here to stay, and OSA is prevalent in an obese patient, and that's what we're here to talk about. So let me just share my screen again. All right. So my goal today is to raise awareness so you can recognize patient in front of you has potentially at risk for OSA or OHS, and to realize that we can do a better job perioperatively to minimize their risk. So we always talk about smoking.
Join the meeting.
Oh, it's horrible for you, you know. Well, smoking on average shortens your lifespan by about a decade, right? So in the US, average male life expectancy is 77 years, and smoking takes about 10 years off of that, right? So I always tell my patients who are smokers, said, you know, listen, I know it's super addictive. You know, Surgeon General Koop said nicotine is more addictive than heroin. Understand that you're addicted to this, but just so you know, like this is going to take away like 1/7 of your lifespan on average, you know, and that doesn't count for the, patients who have an earlier heart attack, but overall it's about 10 years. But what really blows me away with sleep apnea is so severe obstructive sleep apnea has been shown in the literature to decrease lifespan by 18 years, right? And so this disease, which is super prevalent, is worse for you than smoking. And I feel like a lot of times the primary care doctors aren't giving it enough attention. So, we want to talk about making a difference in your patients. You have a patient in front of you and you recognize that they have untreated sleep apnea. You have the real potential to improve their lifespan if you can get them plugged into a way to get worked up and managed. So, just to try to draw some attention to sleep apnea, a lot of celebrity deaths were related to sleep apnea. So basically, if you have sleep apnea, you're fivefold more likely to die in your sleep than if you didn't. And some of these recent celebrity deaths, like well, not all recent, as in President Taft there, but Gandolfini, John Candy, I don't know if you remember the guy in The Deadliest Catch, the ship captain, Jerry Garcia, this singer to the right upper picture, Israel Kamanakooli. It's an amazing voice, but he died at 32 of obesity hypoventilation syndrome. President Taft, Reggie White, even they say Carrie Fisher on her last flight, they noticed that she was snoring a lot while sleeping, and that was normal for her. And I'm not saying that it was death related to hypoxia, but when you have an apneic episode or hypopneic episode, your oxygen drops, saturation drops, your body, sleep is supposed to be restful. You're supposed to go to sleep to wake up the next day feeling great. If you're constantly waking up throughout the night, you're releasing cortisol and norepinephrine, and your blood pressure's up, and these are all risk factors for cardiac events. So it's very, very prevalent. They say that 1 in 4 men have sleep apnea, and 1 in 10 women have sleep apnea, right? So just try to think about that for a second. Today, you're going to have 4 patients. One of them potentially, based on the data, would be sleep apnea patient. So what do you see with OSA and OHS? Well, daytime somnolence, right? So patient just falls asleep at the traffic light. You look at them, they look tired. They can't read a book. They suffer from loud snoring. So when we talk about stop bang, we talk about snoring, talking about loud snoring. Like everyone's entitled to a little, it's not the end of the world, but that loud snoring that you hear from the room next door is what we're talking about. Now, choking during sleep is something you can really ask the significant other during your anesthesia interview if that occurs. And then restorative snorting. So restorative snorting is when someone's sleeping and they do that kind of like cartoon, right? So they're sleeping, they're snoring, maybe they're having apneas, and then all of a sudden they're like, that's a restorative snort. So it's a loud snort that follows an apnea as the patient partially awakens and reopens the upper airway. Very specific for sleep apnea. Hypersomnolence, impaired concentration and memory. You'd be amazed. I mean, I have personal anecdotes in my patients who I got on BiPAP who come back and say, my entire life has changed. I feel alive. I feel able to focus. And, one person that comes to mind, I met him for bariatric surgery. I took one look at him, recognized OHS, did a room air gas, his PSO2 is 65. We got him plugged in, got him on BiPAP. Mind you, he just got in a car accident because he fell asleep at the wheel. got him on BiPAP, and it changed his whole life. It even jump-started his weight loss because he just felt so much better. And also you open their mouth and they have crowding in there. They have, thick neck, big tongue, small mouth. These are all things that you can recognize for obstructive sleep apnea or OHS. All right, so we have our stop bang questionnaire, right? So you should take your patients through this. Do you snore, right? And I'm talking snore loudly. Are you tired during the day? Has anyone observed you having an apnea? So they watching you sleep and they see that you stop breathing. Like he stops breathing while he sleeps. That's an observed apnea. High blood pressure. So again, another comorbid condition that the OSA, which is leading to cortisol and norepinephrine, is leading to the hypertension, and you can eliminate their hypertension often by treating their obstructive sleep apnea. BMI over 35, age over 50, neck circumference. Neck circumference is a little tricky because women don't really know their neck circumference like men do, because men get the shirts and they know that, I'm a size 15, 16 neck or whatever. But I think that one was updated to 18 inches for the neck circumference, and a male. All right, so what does this mean when you get a score of 3, right? So you could see that if you're a male over 50 with hypertension, you already have 3 points, right? And so you screen positive for at risk for OSA. But a male 50 with hypertension, you can see how you can have a false positive there. So the specificity depends on which ones you choose. If I have an obese patient who snores, who's tired during the day, those 3 points are going to be more specific than the male hypertensive who's 50. That being said, if you have greater than 3 to detect moderate to severe OSA, the sensitivity of stop bang score of greater than 3 to detect moderate to severe OSA and severe OSA is 93 and 100%. So in other words, you're not going to miss severe OSA with this questionnaire. That's sensitivity. Will you miss the disease? So this questionnaire is very sensitive. How specific it is, does a positive mean you have sleep apnea? Depends on which ones are positive, but the positive predictive value increases as more of them are positive. And again, a screening tool is meant for you to get the follow-up test, which would be a sleep study. Now, there's also this Epworth sleepiness scale, and I don't do this routinely, but sometimes I'm trying to tease out if someone has tiredness during the day. And you can run through this, how likely are you to doze off when you sit and read, watch TV, lying down to rest in the afternoon, sitting, talking to someone, and you come up with this score, and an abnormal score would show you that you do have tiredness or sleepiness during the day. Now, by the way, this is benefit for your family as well. Like, use this talk to screen at your next big family party whenever they reoccur to see who there potentially screens positive so you could get them worked up and treated. All right, so we talked about 1 in 4 men, 1 in 10 women, and the reality is that most don't know they're positive. They don't know they have sleep apnea.
Kathy Russo
joined the meeting.
Common occurrence is spine surgery, right? Big burly fella comes in and you take one look at them and you know that they have OSA, but no one's ever talked to them about it before. So very frequent. And then the question is, what do you do with that information once you have it? All right, so sleep study. Sleep studies provide an estimate of severity, right? So we have this thing called the apnea hypopnea index. We talked about apneas are no flow and hypopneas are 50% reduction in flow. So they look at that while you sleep, and in the period of 1 hour, they count them. And everyone's entitled to up to 5 per hour. So if your AHI is 4, you don't have sleep apnea. If it's 5 to 15, it's mild. If it's 15 to 30, it's moderate. And if it's severe, it's greater than 30. Now, they also look at how your saturation drops. So if you spend, 3/4 of the hour with a saturation in the 80s, that's a bad sign for severity. So it's not all about AHI. It's also about the nadir of your oxyhemoglobin saturation. And in the sleep studies that you get at a sleep center, they're also monitoring your EKG and looking for arrhythmia. But I want to tell you all now that this can be done at home. So you go see a standard pulmonologist like Dr. Solis at the hospital, and he can order you a home sleep study. And in the mail will come a pulse oximeter, a little finger blood pressure monitor, and some other sensors. You sleep with it and you send it back in. So that whole I have to, spend $4,000, I have to have someone watch my kids, I have to miss work, that can now be eliminated. You can do a home sleep study on the weekend. All right, so I always heard this Pickwickian syndrome talked about, especially pediatrics. Dr. Winikoff told me, oh, it looks Pickwickian. So, where did that come from? So Pickwickian syndrome, it's named after a character, Samuel Pickwick, in the Charles Dickens book, The Posthumous Papers of the Pickwick Club. Dickens was able to capture quintessential aspects of English life in the mid-19th century, and readers were able to see themselves and accept themselves because of Dickens' skillful use of humor. So Samuel Pickwick, who was the main protagonist and founder of this Pickwick Club, was this round face, big belly, somnolent guy who ended up taking on this name Pickwickian. And when Pickwickian body type is recognized, you want to consider OSA, and especially you want to rule out OHS. All right, so let's dive into OHS, obesity hypoventilation syndrome. You will see these patients, and not everything in medicine is intuitive. Some things you have to know what to look for, and that's why I want to point this out. So this is the look, by the way. This is Israel Kamrakwali. I said he died at 32, died at 38, actually. And this is the look. It's very large body weight, big neck circumference, central obesity, little bit hypoxia, tired looking, tired eyes, falling asleep while they talk to you. If a patient falls asleep while you're doing the interview and they have this body habitus, OHS, right? So you have to have obesity, and you have to have a PaCO2 of greater than 45 while you're sitting there, right? So some people get a little hypercarbic while they sleep with OSA, but we're talking about daytime hypercapnia. So obesity and daytime hypercapnia that can't be explained by other sources of lung disease. Alveolar hypoventilation occurs when the normal compensatory ventilatory mechanisms that maintain fail, right? So I'm going to go through each of these four things. Obesity. BMI increases the likelihood of OHS. You actually make more CO2 with increased body surface area, right? And so as you get heavier, you make more CO2 and you have to eliminate it. Now, there's also contribution from the obstructive sleep apnea. So the hypopneas and the apneas due to partial complete airway obstruction can lead to elevated CO2. Now, your pH is always going to be normal because your body's going to make an adjustment, right? So you sleeping, or you can't get rid of your CO2 is climbing. Your medulla sees the CSF pH, and these chemoreceptors tell you to breathe faster, right? But if you still can't eliminate the carbon dioxide, your kidneys are going to hold on to bicarb, right? So your CO2 goes from 38 to 58. Your body's going to maintain a normal pH, so you're going to retain at the kidney level bicarbonate. And this is so important for you because we get SMAs on pretty much all surgical patients. If you look at that SMA 7 and the bicarb is over 27, they screen positive for at risk for OHS, right? So you have a morbidly obese patient with all the characteristics I described. You look at their SMA 7 and the bicarb's 23. They're probably not OHS. Now, one caveat is if their bicarb is lower because they're in DKA, they have a dead bowel, they're in an acute acidotic state, then forget it. But assuming that they're obese and they have the stigmata of the disease and their bicarb is 23, they're probably not a daytime hypercapnic. But let's say it's 33. All right, so you're called down for a hip ankle fracture. This is a real case. Ankle fracture, you look at the bicarb, it's 33. What do you do there? How do you confirm that they have OHS? Well, you do a room air blood gas. And guess what we're really good at doing? Quick room air blood gases, right? So you have a patient, you look at the patient's obese, BMI is over 30, stigmata of OHS, bicarb's 33, meaning greater than 27. You stick the artery, you run the blood gas, and you see that the PaCO2 is 70. Well, that's OBC hypoventilation syndrome, assuming there's no other lung disease and he's not narked out and other things that can make CO2 rise. And I want to say there's also false positives for elevated bicarbonate, like retaining bicarb from contraction alkalosis, or vomiting, or different things that can lead to alkalemia. So, but the room air gas shows the CO2 elevated. You've made that diagnosis. All right, so our first two contributors is the elevated body weight, which makes more CO2. The more surface area, more CO2. And then the sleep disordered breathing. So the sleep apnea, you can't get rid of it because every time you doze off, you're not breathing, right? AHI, right? I told you it can be 0 to 5, 5 to 15, 15 to 30, or greater than 30. I've seen an AHI of 72, right? And it was a surgery center patient coming for ACDF at an outpatient surgery center. And 72 times an hour, he would wake up. So he never slept for more than a minute. Do you think that he's going to have a restful day after that? So sleep disordered breathing can contribute to the inability to get rid of CO2, as well as just the increased body surface area. Now, as the brain gets all messed up, you also might hypoventilate centrally. And also remember, like in a lot of the syndromic kids, they may have central hypoventilation, right? So, apnea is from the brain, not necessarily obstructive. So we have obstructive sleep apnea, but we also have central apneas, which are about 10% of apneas. And as OHS worsens, the brain changes, and then some of those, even if you fix the sleep disordered breathing by putting them on BiPAP, they still may have an elevated AHI because their brain has changed. Those are central apneas. And sometimes those are managed with tracheostomy in these patients. All right, so be alert for the possibility of OHS when obese, and AHI is great. And also you'll notice when you do a pulse ox on the patient in holding area, saturation is like 89, 92, and I'm going to get into a deep dive of why that occurs as well. Now also, so the third reason we have obesity, we have sleep disordered breathing, and the third reason for OHS is impaired pulmonary mechanics, right? So this is all very board relevant, this slide, like suck in this slide. So fat around the abdomen, fat around the chest, it reduces compliance. So your total lung capacity, your ERV, your FRC, your FEV1 to FVC ratio is preserved. So what is that? That's restrictive lung disease, right? So obese patients, and especially if there's a laparoscope in their abdomen and there's pneumoperitoneum, that's restrictive lung disease. So that is one impaired pulmonary mechanic that leads to OHS or hypercapnia, or a mechanism of alveolar hypoventilation. The work of breathing in these patients is 90% greater than the work of breathing in a thin patient. 90% more effort to breathe, right? And so this ultimately leads to failure. Body compensates, it compensates, it compensates, but ultimately it fails. And then we have VQ mismatch, right? So ventilation, I breathe in, I put ventilation in my alveoli. My pulmonary arteries spread blood to the alveoli, to the capillaries, and there is a VQ match. So there's ventilation and perfusion. They match up pretty good, and I have gas exchange. But when I'm obese, I have poorly ventilated lower lobes because my livers are pushed up. My liver is pushed up and decreased lung compliance. So I have poor ventilation there. That's going to be shunt. We also have increased lower lobe perfusion due to increased pulmonary blood volume. And the OHS pattern of breathing is characterized by low tidal volume and increased respiratory rate. So since I can't expand my lungs real big, I just take small tidal volumes with an increased respiratory rate. And that compensates for a while, but it's not enough. And it leads to more dead space, right? So dead space is the conducting parts of my airway that don't gas exchange, right? So from the respiratory bronchial distal, we gas exchange, but my mouth and my trachea and my bronchus, they don't exchange gas. So if I'm taking a smaller tidal volume with a higher respiratory rate, I'm going to have more overall dead space in my minute volume. All right, another great board slide. You need to understand this, and I'm sure you already do because it's basic. But here is a normal tidal volume. Then we have our inspiratory reserve volume. And then we push the air all the way out as hard as we can. That's our expiratory reserve volume. And then we take our normal tidal volumes again. So these two lines are our tidal volume. The expiratory reserve volume is everything I can push out to my residual volume. And my FRC is my expiratory reserve volume plus my residual volume. And I just want to point out that every obese patient that you induce, you should be pre-oxygenating in the reverse Trendelenburg position. Because as that belly hangs down in the reverse Trendelenburg position, the diaphragms are pulled away from the lungs, compliance improves, your FRC improves. Because as you know, pregnancy, obesity, supine position, they decrease your ERV. So we can improve our ERV. What happens when I induce anesthesia, right? So I'm pre-oxygenating, I induce anesthesia here. I'm left with my FRC in my lung. And that's 2 liters in a normal person, right? So if we've pre-oxygenated 100% oxygen, and our O2 consumption is 3 mLs per kilo per minute, which is 200 mLs a minute. If I have 2 liters of oxygen in my lungs, I got plenty of time to putz around with my intubation if I can't get it. I'm not going to desaturate quickly. But the obese patient has a reduced expiratory reserve volume. So when you induce them, for 2 reasons, dynamic airway compression, but also expiratory reserve volume being small, they're going to desaturate very quickly. So whatever you can do to increase FRC or ERV before induction of anesthesia will improve the amount of time you have before the desaturation. So you want to have your patients pre-oxygenate in reverse Trendelenburg position, and you want to tell them to really recruit. You want 5 full capacity breaths. Pull the air in as deep as you can, push it out, out, deep, 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 deep. You want 5 of those to get rid of all that nitrogen and fill that FRC with 100% oxygen in case you have a difficult airway and you can't ventilate. It give you more time. All right, so let's look at this real closely. We have our non-obese patient. This blue line is called the closing capacity. The closing capacity is the point at which you get dynamic airway compression. So remember, the pleura, the negative intrathoracic pressure, it's pulling the lung open. But when you exhale and you push the air out, at some point, you're going to have some medium-sized airways collapse. And when you have an airway collapse, you lose ventilation. You develop shunt. So in your ERV, you will have a point at which you will have dynamic airway compression, and that will be shunt. But guess what? It doesn't bother us because it doesn't occur in our normal tidal volume. But look at this. As you get obese, your ERV, which is the red line, shrinks. So instead of this big, long ERV, we now have a small ERV. And but the closing capacity point does not change. It stays in the same location of the spirogram, but since your tidal volume is now where your ERV used to be, the obese upright patient has shunt while they're sitting there talking to you. So when you put a pulse ox on a patient and their saturation's 89 and you've ruled out other causes, They may be having dynamic airway compression or shunt in their normal tidal volume. Now lay that patient flat and look at their ERV, it's gone. Now put your patient Trendelenburg during a robot. What do you think happens to the ERV, right? So you're doing a robotic prostatectomy on an obese patient and the saturation is 89 and you're on 100% oxygen. Well, guess what? They're having tons of shunt. And so if you can negotiate with the surgeon to have less Trendelenburg in that patient, or potentially they're not a robotic candidate if they're too obese, et cetera, that's the argument you make. So if I can take the obese patient and put them in reverse Trendelenburg and get less shunt, I'm going to have less hypoxia. So continue talk about impaired pulmonary mechanics. We have reduced respiratory muscle strength. We have reduction in respiratory muscle strength and endurance, worsen the supine position when work of breathing is increased. So remember, look at these two pictures. Which one's going to be easier to breathe, right? So 90% increased work of breathing. So reverse Trendelenburg will help you there. And obviously, you know, if you can give a little BiPAP, that will also improve. But this is another reason why the OHS patient can't get rid of their CO2. And it's why you'll find that these patients sleep in their recliner. So they may not even realize why they sleep in their recliner, but they're sleeping in their recliner because they have a larger ERV and less dynamic airway compression and less work of breathing. And so sitting up is always better. So one of my communication orders that I put in Cerner with the OSA suspected patient, you know, I have a communication order that I saved that says, I suspect this patient may have obstructive sleep apnea. Please minimize the use of opioids, focus on alto, keep the head of the bed at 30 degrees at all times. I never want this patient lying in this position in their hospital stay. Side lying, head up, and belly lying are good, but lying flat like this increases your AHI, it increases hypoxia and all the things we spoke about. So I have this communication order to bring attention to the nursing staff that I suspect this patient may be at risk. And don't give them a milligram of dilaudid. Don't, you know, let's focus on the Toradol and the Celebrex and the Tylenol. Let's sit them up. Let's use non-invasive ventilation when needed. Let's have increased vigilance and keep an eye on them. Okay, number 4. So that was the first 3 reasons why you develop OHS. Number 4 is altered ventilatory control. So obesity is associated with increased respiratory drive to maintain eucapnia. Individuals with OHS do not demonstrate augmented drive. Ventilatory drive to hypoxia hypercapnia is diminished. And my brother, when he was a pulmonary fellow at Sinai, did some work with leptin and its role in OHS. But let's talk about this oxygen for a second. I told you that the kidneys retain bicarb to maintain your pH, right? So your patient doesn't care that their CO2 is 80 because their bicarb is 35 and their pH is normal. So they don't have that medullary drive of increased acid in the CSF. So they don't care about the CO2. But they still have drive because of hypoxia. So as their saturation drops to 86 while they're sleeping, they have hypoxic drive to breathe. But us, in our infinite wisdom, under the anesthesia, we give them 100% oxygen because we love seeing 100% saturation on the screen. Mistake. It's a mistake. Because when that patient wakes up, they have been seeing the superoxia and they don't have the drive to breathe. Your goal saturation in the recovery room and during the case is 92%. You don't want 100%. You want that. You don't want to overwhelm that drive with too much oxygen. Putting an OHS patient on a non-rebreather in PACU is a mistake. Your goal should be adequate ventilation as determined by the CO2 level, which you need to monitor in certain situations, but also to maintain a pulse oximeter around 92 in these patients, because if you give them a non-rebreather, they don't mind that CO2 is high, and now they have plenty of oxygen, so they will stop ventilating, right? Giving a lot of oxygen, you may not have hypoxia, but you may have hypoventilation. And as the CO2 climbs, right? So they're 80, and I've watched this occur so many times. Then they're 90, then they're 100, they become somnolent. And everything looks fine because they're not in pain, they're laying there. Then it's 110, then it's 150, then they lose consciousness. And that's when you hear stat intubation in recovery room. So you have to prevent that. And how do you prevent that? Vigilance. You have to maintain ventilation. And that may be with non-invasive ventilation, which I'm going to discuss. All right, so we have serum bicarbonate. Anyone you suspect for OHS, look at their bicarb. If it's greater than 27, it's 9 out of 10 of those, 92% sensitive for identifying OHS and get a room air blood gas. You'll notice on the OHS patient that the saturation is not good, and that's because of dynamic airway compression and shunt. And you might even see polycythemia, and again, hypercarbia on ABG. Okay, so the general approach to these patients, we want to get CO2 normalization all the time, 24 hours a day. We want to normalize it. We want to prevent severe desaturation because, oxygen is important. We want to prevent erythrocytosis, pulmonary hypertension, ultimate cor pulmonale. And we want to relieve hypersomnia and altermentation. So how do we do this? We give positive airway pressure while they sleep. And lifestyle modifications like losing weight, bariatric surgery, once they're stabilized, etc. So positive airway pressure. Patients with OSA and coexisting OHS are usually managed initially with continuous positive airway pressure. So most people get put on CPAP, and once they fail it, they'll get put to BiPAP. So CPAP is usually the starting point. Machines are typically set for an auto titration. So the new machine, so the old machines, the patient would be like, oh, I tried CPAP 10 years ago. I hated it. It was too much air. And that was because machines were set to a number, like 15. And it might be too much for the patients. But the new machines are called APAP. They automatically titrate the CPAP or the BiPAP to the AHI. So they recognize a stop point, and they're much better tolerated. Plus, there's much better masks. There's nasal pillows now instead of a full face mask. Overall, if a patient tells you they failed in the past, you might want to tell them the technology's improved and to try again. So nocturnal, non-invasive, positive pressure ventilation decreases PaCO2 tension and daytime sleepiness. In a retrospective study of 130 patients with BiPAP or OHS, they found the 1, 2, 3, and 5-year survival rates of 98, 93, 88, and 77%. These survival rates were better than the 18-month survival rate of 77% in a prospective cohort who didn't get treated. So 18 months is about, it went from 77% survival without it to 93% survival. That is a large absolute risk decrease from this therapy. And I want to point out that oxygen can be dangerous. Now, sometimes it is supplemented, but it's always supplemented in the setting of giving non-invasive ventilation. So you're not going to just give oxygen to an OHS patient. You're going to give oxygen with BiPAP. And we'll want to shoot for that 93% sat. And you'll see patients mismanaged. They say, I'm on HOMO2 and they're this obese and they're not on BiPAP. That's a mistake. They're just treating the hypoxia. They're not treating the alveolar hypoventilation. Now, sometimes tracheostomy is needed, but typically non-invasive positive ventilation is tried and tried and tried, and we rarely have to get to tracheostomy. But I've personally had a patient who failed multiple extubations and ultimately needed tracheostomy. Was eventually decannulated, but there are times when it's so severe that tracheostomy is the treatment. All right, so that is the first part of the talk. It's obesity hypoventilation syndrome. I want you to recognize it by seeing a morbidly obese patient with severe somnolence, maybe a little bit decreased saturation, elevated bicarb. You do a room air gas and the PaCO2 is greater than 45. Once you have that patient in front of you and you know they need surgery, you have to decide, is it an elective surgery or an emergent surgery. And if it's elective, they may want to get a workup and treated prior to proceeding with the elective surgery. But if you are going to proceed, there has to be multiple discussions about risk versus benefit, discussion with the surgeon, discussion with, how much post-op opioids are needed. If we're doing a case that there's no pain post-op, that's a different story than a multi-level spine fusion that's going to need a lot of opioids. Because your AHI, I think I have a slide on this later, but your apnea-hypopnea index is actually the worst on the third post-operative day. Let that sink in for a second. So you're at home, your AHI is 65. So 65 times an hour, you're waking up and you're stopping breathing, desaturating. Then you come to us and we give you propofol, sevoflurane, narcotics, post-operative opioids. You think that AHI is going to be better or worse? It's going to be worse post-operatively. But even deeper than that is your sleep architecture is affected. And the AHI in the studies is the worst on the third post-operative night. So that's when the patient's home, right? So patient comes in, they get ACDF, they stay the first night, maybe the second night they go home. But that third night at home, when they have a swollen neck, you intubated them, tissues are swollen, their head was down, whatever it is, they got tissue swelling, everything that's going to make the AHI worse already. Then they're going to take 2 Percocets. Then they're going to have change in sleep architecture to make their AHI worse. So that third post-operative night is actually very dangerous. And that's why we need to have preoperative talks with the patients. Like, listen, you need, whenever you're sleeping, even if it's napping during the day, you need to wear your CPAP BiPAP. You really need to minimize your opioid consumption. You know how your wife says you snore really loud? Well, the opioids are going to make that worse. We want you to take,
Join the meeting.
Celebrex, 1,000 of Tylenol. We want you to, use other approaches to pain management than just the respiratory depressants and opioids. And certainly want to avoid sleep adjuvants like, Ambien on top of it, right? So the preoperative talk is, listen, you have this disease. It gets worse the third postoperative night. It's really important to wear your BiPAP, CPAP for the whole perioperative period to minimize opioids, to sleep sitting up. That's a big part of that discussion. Okay, so let's talk about OSA. I did the OHS first because I wanted to really make an impact with it, but let's talk about OSA. All right, so the ASA perioperative management of OSA recommends that you maintain a high index of suspicion for OSA. I see a lot of anesthesiologists focus on the stress test, and that's not where my focus is. I evaluate exercise tolerance, right? So we have the ASA, the cardiac patient for non-cardiac surgery guidelines, we look at, their RCRI, revised cardiac risk index, and we look at their exercise tolerance, and we'll move on to surgery. It's like total knee, I need an echo under stress. No, they have good exercise tolerance. You don't need those things. Their RCRI is low. You don't need those things. But they'll totally look past, and I see this in the medical clearances frequently. They haven't addressed the OSA, and that's really where their perioperative risk comes from. So we want a high index of suspicion for OSA. We want to carefully use medications. So 0.5 milligrams of Dilaudid is equal to 3.5 milligrams of morphine. That is a good analgesic dose. Don't need to give 1 milligram to the patient who's at risk for OSA because remember, their AHI is high. It's going to be worse with that much opioid. So maybe a smaller dose. Give the ERAS meds pre-operatively. You have an OSA patient, you can do your patient a service by getting them 1 gram of Tylenol and 400 of Celebrex in before they go to sleep. Because when they wake up, those will be working, circulating blood level, and they will have a massive reduction in opioid consumption. Tylenol alone decreases opioid consumption by 1/3 to 1/2. 1/2 the opioid. Is that going to be a benefit for an OSA patient? Yes. The Celebrex or Toradol is going to lower the pain score by 1.5 points. So these two interventions can drastically reduce postoperative opioids. And then we want vigilant monitoring for upper airway obstruction. So a lot of big centers now, they have a large BMI. They'll actually stay in the operating room for 5 full minutes after extubation to make sure ventilation is good. So let's say you extubate and the patient is hypoventilating. That patient's going to need non-invasive ventilation in recovery room. And that's something you can order. I'm going to teach you how to order it in a little bit. Or they may need to be reintubated or reversed or given more time, whatever it is. But if you just pull the tube out and get in the hallway, that's when you get those stat intubations in recovery room that we don't want. Remember, in the operating room, much more comfortable intubating. We're on the OR bed, patient's ramped, machine is there. We have all our blades and tubes and tongue depressors and airways. The PACU, when the CO2 is 150 and the patient's at the foot of the bed and you're trying to intubate them upside down, not good. So sometimes it's best if you suspect a challenging or severe OSA to stay in the room a little bit extra until you're ready. And beyond that, you might want a prolonged PACU stay. So let's say you get to recovery room and the patient's obstructing and desaturating. Well, that's also going to happen at 2 a.m. when the patient's on the floor and gets given dilaudid. So you have to recognize at that point after ACDF, where you see someone desaturating and having apneic events, that they need a higher level of care. They may need a monitored bed with tidal CO2 or pulse oximetry. They might need non-invasive ventilation post-op. They may need a talk with the surgical team of what they should not prescribe. They may need intervention from the pulmonology team. And so we can't go to recovery room, see an episode of hypoxia and desaturation and obstruction, and then just not tell the next team about it. We have to get that message in a post-operative note, in talking to the next team of what needs to be done to vigilantly care for this patient. And that's that whole integrated team approach. All right, so why is OSA worse around anesthesia? So anesthetics reduce airway reflexes, dilator tone. Like in your mouth, you have a bunch of muscles like tensor palatini, genoglossus. All these muscles are holding your pharynx open. So when you give some propofol, all that stuff sinks in. And so whatever the AHI is, it's going to be worse post-operatively. We go and intubate, get a little edema in there. They pack the nose. In a ENT case, head down the whole case, everything swells. I mean, you see after a 10-hour spine what the eyeballs look like. That also happens in the airway. So again, it's all things that are going to make it just a little bit worse. Supine position is worse for OSA. Now, the other thing is afterwards, the patient may be in pain or have had head and neck surgery, or they're agitated. They have an NG tube, all reasons that they may not wear their CPAP post-operatively. And so those are all reasons why sleep apnea is worse after surgery than the day before surgery. Now, also, sleep deprivation worsens OSA, and a common perioperative concept is to have anxiety, to be in pain, to be in a hospital environment where you don't sleep well. This leads to an increase in REM sleep, which is the stage of sleep where OSA is typically most severe. And like I said earlier, sleep disturbance is greatest first post-op night. AHI, or the apnea-hypopnea index, is worse on the third night. More invasive procedures require more anesthetic agents, sedatives, opioids. So that's the difference between a colonoscopy, where there's no post-operative pain, and it just matters that you manage the airway in the immediate perioperative period, but that patient will be safe to go home, versus a multi-level spinal fusion, which is going to be a week or 3 weeks of opioids, severe pain, severe sleep disturbance. And so your decision tree is different for the patient who comes for a painless quick cysto, where you just have to manage that airway intraoperatively and postoperatively, but they'll be fine that night, versus someone who's going to go home and be on 2 Percocets around the clock. And these are the problems we see in OSA patients. We have emergent intubations. We have difficult intubations. We have extubation, difficult extubation courses. You know, they're not breathing great, and we're working hard to keep them safe. We have patients who obstruct can get, normal pressure, pulmonary edema. We have respiratory arrests. We have profound desaturations. So all of these things are why we have to be careful in our OSA patients. Now, Preoperative OSA treatment should the case be delayed. So you have a patient in front of you who's not on BiPAP, not on CPAP. Should you delay this case? Well, it depends on multiple factors, but patients with CPAP for more than 2 weeks improve physiologic outcomes, hypertension, pulse ox, AHI. And so there was an open label trial of patients who had an AHI greater than 15. They were randomized to no treatment or auto-titrated CPAP for 3 preoperative and 5 postoperative nights. And they had improved post-op pulse ox and decreased AHI. So instead of obstructing and waking up 30 times an hour, they woke up 3 times an hour with treatment. So there's evidence that treatment improves outcome as far as your AHI goes. Doesn't mean you should cancel every case that you suspect OSA, but you need to tease out the severe cases. The patient who's falling asleep in front of you, the daytime hypercapnics, the patients who look moderate to severe and are going to have a hard post-operative course. Those are the ones where the discussion can maybe be around optimization. But even more fruitful is discussions with your surgeons that, hey, when you see a patient in the office for the first time and you recognize OSA, plug those patients into the pulmonologist so they can start their workup. Let's say a patient comes in with radiculopathy. They're going to go through a whole scenario of epidural, transforaminal, discectomy before their fusion. So if early on in their treatment plan, they can say, hey, go see Dr. Pulmonary over here to get worked up, that would be your best bet. Because remember, canceling a case doesn't go without consequence. Patient may have been worried about this for months. They may have went on disability. They may have arranged for childcare. They may have used up their PTO for, scheduled it for the surgery. The pre-authorization, the room might be open, the surgeon's time, your time. So canceling a case has a lot of consequence. And so you want to make sure that you're doing something evidence-based and it's the right thing to do. All right, so preoperative OSA, inpatient or outpatient surgery. This is a very individualized decision. You look at the age, the comorbidities, the type of surgery, the type of anesthesia needed. Certainly a spinal is always the way to go if you can avoid the central depressant effects of volatile anesthetics and opioids. By doing a spinal, you will decrease mortality. So a spinal in an OSA patient decreases mortality. You don't see that too often. When we talk about spinal versus general, does it increase mortality? In the OSA patient, it does. The following patients are reasonable for outpatient surgery. And this is assuming you're comfortable with the airway. Superficial procedures, lithotripsy, arthroscopy, cataract surgery, superficial surgery, colonoscopies. Surgery with no postoperative opioids may be performed in patients with known or presumed OSA if they will comply with recommendations for post-op for the positive airway pressure therapy. Now, remember, you might want to do a prolonged PACU stay. So you may want to keep them in PACU extra amount of time to make sure that they're not having events. If they're not having events in PACU, they're unlikely to have events on the floor. I'm running short on time, but this is just a sample PACU policy that revolves around vigilance, that revolves around monitoring a sedation scale. You want to recognize advancing levels of sedation with a sedation scale around your opioid dosing to make sure that it's not too much, because whatever dose is working for them in the PACU would be a good dose for them on the floor. Like, why would you give 0.5 milligrams in PACU and then the surgeon orders 1 milligram of dilaudid on the floor? So you can communicate that to that team. All right, so let's talk about positive airway pressure in OSA. So this is a screen of one of our BiPAP machines. And you can see you have an IPAP, the inspiratory positive airway pressure. That's how much push it gives as they breathe in. So it senses the breath, it pushes in that much pressure. And then when they exhale, the EPAP is the expiratory positive airway pressure, is the number that it keeps the airway open. So if there was no EPAP, everything would collapse and you would snore. So the EPAP, which is basically your CPAP, it's continuous throughout the respiratory cycle. is to keep everything open. So if it was just CPAP, you would just choose a number for that continuous. But BiPAP, there's an inspiratory and an expiratory. All right, so when do you order CPAP? For hypoxemic respiratory failure, right? Because we know if we keep oxygen in the alveolus, we're going to have increased air exchange. OSA, pulmonary edema, CPAP decreases preload, and it's good for pulmonary edema. It increases the FRC and it opens collapsed airways. It also, CPAP reduces LV transmural pressure. So transmural pressure is the pressure on one side versus the other side of the ventricle, of the myocardium. And the more positive airway pressure, it reduces LV transmural pressure because there's less of a gradient there. And that increases cardiac output. So CPAP is a modality of choice in pulmonary edema, and pressures are usually between 5 and 15 centimeters of water. CPAP provides positive airway pressure throughout all phases of spontaneous ventilation. And here are some of the things that CPAP does. It splints the airway open. It increases positive intrathoracic pressure, decreases afterload, increases cardiac output, decreases venous return, increases lung volume. So routine CPAP, like just ordering CPAP on everybody, is not really usual practice. But if you're noticing that they're obstructing, then CPAP can be used. You can also use it in known OSA patients who are receiving CPAP. CPAP therapy will reduce the risk of complications, preserves the airway patency, and over several weeks, preoperatively, it can improve diminished reflex responses to hypoxia and hypercapnia. Now, if you see a patient in PAT, say it's very important for you to use your CPAP the night before surgery because there's a carryover protective benefit in as little as 4 hours of use the night before. So if you use your CPAP the night before surgery, you'll do better the day of surgery. That's been studied. All right, so again, CPAP, it's just one pressure. It shows the patient's volumes and the flow of the machine. So the minimum CPAP you would order is 4, and the maximum is 20. And if you wanted to titrate it at the bedside, you could start it and go up by 1 centimeter of water every 5 minutes until you see the following not occur. Less than 2 obstructive apneas, 3 hypopneas. RERAs are respiratory related arousals, which is basically not quite an apnea or hypopnea, but they wake up a little bit. So anyway, CPAP, you can start it at 8 to 14 if tolerated and titrate to a volume of 8 cc per kilo of ideal body weight. You don't just set 8 and walk away. You have to sit there. Now, the respiratory therapist is extraordinarily helpful here. They will come down and they will help you through it. Say, listen, I have a patient here with suspected OSA. I want to give them non-invasive pressure ventilation to help them breathe better. Can you help me titrate it? So we start the CPAP at 8. They will fiddle with it. Maybe go to 9, 10, 11. Find a great 8 cc per kilo of ideal body weight volume. And that will be their CPAP setting. All right, now BiPAP. So we talked about CPAP for pulmonary edema, for hypoxia, for OSA, but transition from CPAP to BiPAP when CPAP approaches 15. So if you're setting a CPAP as 15 or 16, that's a lot of air coming in, and it's a lot of air to breathe against on your inhalation. So you might move that patient to BiPAP. It's also uncomfortable. If the patient's saying too much air, they might do better with BiPAP. So BiPAP is beneficial in patients with respiratory fatigue. So if your work of breathing is hard and you look at someone and they're tiring out, CPAP may not be enough. They may need a little help with the IPAP, inspiratory positive airway pressure, to get some air in so they don't have to do as much of the work of breathing. BiPAP is an effective respiratory modality when patients are not improving sufficiently on CPAP and inspiratory assistance that may further reduce work of breathing. Common practice is to use initial IPAP settings of 10 to 12 and an EPAP setting of 5 or 7. All right, so you set it at 10 over 5. That's where you could start. Then you adjust your IPAP to 15 to 20 depending on the response, just to get that tidal volume of 8 cc per kilo of ideal body weight. We underuse this as a specialty. It's very accessible to us, and it can make an extraordinary difference as a patient is emerging from anesthesia and the volatile anesthesia is coming off and their airway reflexes haven't returned fully yet and they're hypoventilating. This is a great option. All right, so titration guidelines for when and how to switch to BiPAP. When a patient complains that he or she is uncomfortable or is intolerant to CPAP pressures, or when the CPAP is 15 and respiratory disturbances continue, begin BiPAP at an EPAP of 4 or a CPAP level at which the obstructive apnea was eliminated. So in other words, if you're on CPAP of 12, you wouldn't go to an EPAP of 4. You would go, 17 over 12 kind of thing. And you can do them on, if their saturation is good and you're primarily trying to drive ventilation, you can do this on 21% oxygen, 30% oxygen. You don't need to do 50% or 100% or anything like that. All right, so we're going to start therapy at 8 to 14 over 5 if tolerated. Titrate to a volume of 8 cc per kilo ideal body weight. With a backup rate, you can set a backup rate in just like SIMV would have. All right, and again, just be careful with oxygen. It should always be used in the setting of non-invasive ventilation. And we want to just drive up that saturation to 90, 92. All right, so just in summary, OSA, OHS is very prevalent. OSA, very, very prevalent, 1 in 4 men, 1 in 10 women. OHS is 4% of OSA patients, but when it's prevalent, when it's there, it has a lot of perioperative implications because these patients are hard to extubate because they don't have the hypercapnic drive to breathe. So we want to recognize them and come up with a treatment plan. And perioperatively, we want to be very vigilant with our opioids, with our nursing instructions, with our patient instructions. And you also want to plug the patients that we see into a follow-up plan. Tell them what to do. Say, hey, just go see a pulmonologist, talk to your primary about getting a sleep test. That's simple. You don't need to say polysomnography. Say, hey, talk to your primary about getting a sleep test. Say, your anesthesiologist was worried about your snoring. Talk to your primary about a sleep test. And that might be enough. And throw a little data at them. Say, listen, sleep apnea is actually worse for you as far as lifespan than smoking. That you're 5 times more likely to die in your sleep if you have untreated sleep apnea than if you didn't. And I think that'll drive the patient to get worked up and treated. All right. Thank you, guys. I'm sorry I went a little bit over.